Yes, sir. We can start, sir.
Yeah, sure.
Is the speaker available?
Yeah, sir. Yes. Good evening, sir. Yes. So I will just begin it, sir. If you open the panel of. Okay. So very good evening, everyone. And I hope I am, thank you so much, sir. I'm audible and also clearly visible. Yeah. Anyone, so Secretariat, you can confirm. I can see Dr. Gajen sir is smiling, so it means that he can see me.
Yes, sir.
Thank you so much. I'm Dr. Pavan K. Gupta, Member Executive Committee, Association of Environmental and Occupational Health, Delhi, which is Delhi branch of Indian Association of Occupational Health. And I'm Secretary, Association of Environment and Occupational Health, Haryana branch. I can see that Dr. Kumar Narayanan has already joined in, and he's our esteemed speaker for the day. And also Dr. Rajiv Kumar Jain has also joined in. They are speakers of the day, our esteemed speakers. And there are panelists also have joined. So very warm welcome in advance. Thank you so much for joining well on time to our esteemed speakers. On behalf of AOSD, extending a very warm welcome to esteemed speakers and panelists and attendees. And gratitude and thanks to all of you for joining us this evening. As usual, we are very grateful to all of you for making this effort of ours a continuous success. Because without you, definitely, we cannot imagine the engagement, high engagement and continuation. So thanks once again. It is a matter of great pleasure and privilege for me to get an opportunity once again to host 57th webinar of AUHD. So we have covered a long way. We are at 57th milestone today, and a great thanks to all who have contributed significantly for the success. This is under AUHD's ENOC, Environmental and Occupational Health DG Connect initiative. Sincere gratitude and thanks to the executive body for extending this opportunity to me to host this, and also, as I always appreciate the efforts of AUHD Secretariat for their continued hard endeavors to keep the show on despite the challenging times and current pandemic situation. As always, I just mentioned, we have a great lineup of speakers who would deliberate and share their information, thoughts on most pertinent subjects. And today's definitely topic is related to arrhythmias, and we have Dr. Narayanan with us already. Just to quickly touch upon the timelines, as always, we have half an hour slot for each speaker, 20-minute slots, speaking slot, 10 minutes for question and answer. And just to follow some housekeeping rules, we have incorporated an alarm, a signal at 18 minutes, which will give a sign that 2 more minutes are left for the presentation. And then there will be another alarm at 20 minutes to mention that time for the speaker slot is over. And then the last alarm definitely will be at 22 minutes, at which we will open the session for question and answers automatically. And we will request the esteemed speakers to take up the rest of the slides in maybe next sessions whenever we will be able to. But 18, 20, and 22 minutes is what we are going to follow today, so that we give a lot of time to our esteemed panelists and attendees to ask so many questions. Because in virtual seminars like this, it is very important that the reciprocation is fine, so that everybody is engaged and they're able to ask their questions, which is very important. So these are some housekeeping rules that I mentioned. And before I pass on this and take this ahead, I would request that all the panelists and attendees to please keep posting your questions in Q&A box or chat box, and we will take all of them in the order of their appearance, and also you can raise your hands. I will be definitely taking record that whosoever has raised the hand first, we will reach out to the person first to take the questions and similarly take it ahead. So without any further delay, I definitely hand it over to and request our very own Dr. Gajendra Kumar, President AUSD, to please give inaugural address and declare the webinar open. Over to you, sir.
Good evening, friends.
Good evening, sir.
I welcome you all to this 57th issue of our webinar series, which we have started from the beginning of this COVID-19 pandemic. And in fact, this has given us a great opportunity to learn so many topics. Today, topics are very important. I welcome Dr. Kumar Narayanan. I welcome the other speaker, Dr. Rajiv, and as well as I welcome all the participants in this webinar. The topic regarding arrhythmias is especially important because during this last 1.5 years, most of the cardiac patients has been neglected. They were scared to come to the hospital for their routine checkups. There were no OPD services in most of the hospitals. So there was a lot of backlog with these patients for their review and their further management protocols. So keeping in this view, today's topic become very, very important. So with these few words, I welcome once again to all of you and hand over to Dr. Pavan to proceed further. Thank you.
Thank you so much, sir, for your kind gesture. Really appreciate it. With your permission, taking the agenda ahead. And it's a great feeling to introduce Dr. Kumar Narayanan to all the esteemed panelists and attendees. A very warm welcome to you once again, Dr. Narayanan. You can please unmute and let us know if we are able to, you are able to hear us clearly.
Yes,
and also
absolutely. Yeah.
Thank you so much for confirming, Dr. Narayanan. Dr. Narayanan has been really kind to join in a little bit in advance and check all the housekeeping rules. We are really thankful for your gesture, Dr. Narayanan. A brief introduction of Dr. Narayanan, which definitely is not as brief as we think. So, Dr. Kumar Narayanan, consultant electrophysiologist, MD, DM cardiology, FHRS and CEPS Medicover. That's his background, and he is from Medicover Hospitals, Hyderabad. Dr. Narayanan is an experienced cardiologist, electrophysicist at Medicover Hospitals, Hyderabad. He has completed an ACGME accredited fellowship in clinical cardiac electrophysiology from Siddharth Sinai Medical Center, USA, and is certified by the International Body of Heart Rhythm Examiners, IBHRE, as we know. Along with clinical work, he also has keen research interest and is currently involved in research into mechanisms and risk stratification for sudden cardiac death, mainly focusing on clinical risk markers. He is also interested in primary prevention, ICD utilization, epidemiology of atrial fibrillation, and rheumatic heart disease research. He collaborates with the Paris Descartes University and European George Pompidou Hospital, Paris, in cardiac research, where he is visiting faculty scientist. Some awards and recognitions of Dr. Narayanan: Chair, Asia Pacific Heart Rhythm Society, Young EP Subcommittee, that is Electrophysiologist Subcommittee, Best Outgoing Student in MBBS and DM Cardiology, A.V. Gandhi Award for Excellence in Cardiology, Thomas Peter International Mentorship in Cardiac Electrophysiology, and last but not the least, James Willerson Young Investigator Award in Cardiovascular Medicine. A lot of accolades, Dr. Narayanan, and we are privileged and honored to have you here with us. Thank you so much for sparing your time. This e-floor is all yours.
Thank you so much for that kind introduction, Dr. Gupta. And I'm going to share my screen now so that we can get this session underway. So today's topic, which I'm going to touch upon, is the approach to cardiac arrhythmias. And this is something which rhythm disorders of the heart are not just confined to the realm of the cardiologist alone, but a lot of general physicians and people in other fields also may suddenly encounter it, suddenly and unwillingly encounter it. And so it's important to have a broad overview of it. So in the next 20 minutes, I'll try to just cover upon the most broad aspects of how to approach it. And then we could probably discuss some specifics during the discussion. So, a couple of common scenarios which any of you may encounter. Say a 65-year-old gentleman is either brought to the ER or is brought to the OPD complaining of palpitations and dizziness, and you find that his heart rate is 200 beats per minute, his blood pressure is low, and you find this kind of a bizarre ECG sitting in front of you. So what do you do? Or you may have a scenario where an elderly lady is brought saying that I fainted twice today morning. And then when you look at her, her heart rate is only 35 beats per minute, and you have this kind of an ECG. So both of these, will raise a lot of questions in your mind. What should I do? And what is the diagnosis in this case? What should I do immediately? What is going to be the long-term prognosis? Is it enough to do medical management? Is some procedure going to be necessary? So many questions come up in your mind. So arrhythmias, as I said, you can encounter it suddenly and unexpectedly. And the problem is some of them at least can be truly life-threatening. And that makes it necessary that you recognize it promptly and take the immediate next step necessary. This results often in a lot of anxiety in the treating clinician. And the moment they see bizarre kind of heart rates or ECGs, they can tend to panic. And it's important, therefore, here to keep calm, have a systematic approach, and then have some broad principles which can help you in any situation. Before we go to arrhythmias, we should all be clear in our mind as to what is normal rhythm. So we call it normal sinus rhythm. This is the heart rate between 60 and 100 beats per minute. The PP and the RR intervals, which is the atrial and the ventricular activation of the ECG, should be pretty regular. And what we call the conduction time from atrium to ventricle, or the PR interval on the ECG, should also be normal. And lastly, the P wave axis, which is showing you where the P wave is coming from. It should be coming from the sinus node. So typically, because the sinus node is situated in the upper right atrium, you will see that the P waves are positive in the inferior leads and negative in AVR. So when you see this, you can say that this is normal sinus rhythm. Therefore, the first approach to classifying arrhythmias is very simple. Is there a perturbation of heart rate, right? So if the heart rate exceeds 100, then it's going to be a tachycardia or a tachyarrhythmia. If it's just sinus rhythm which is exceeding 100, then you just call it sinus tachycardia. But if the rhythm is perturbed, then you have to make a diagnosis as to what other rhythm it is. On the other hand, if the heart rate is below 60, then it's going to be bradyarrhythmia. Now, there are various different ways of classifying tachyarrhythmias, which we will touch upon. As far as bradyarrhythmias are concerned, there can be different causes, but at a physiologic level, it's either going to be a problem with impulse generation in the sinus node or because of an issue at the AV node or AV block. So let's look at this. Now, to understand bradyarrhythmias, it's good to have a quick revision of the normal conduction system. So the impulse originates from the sinus node, quickly depolarizes both atria, then goes to the AV node at the AV junction. Then below that, there is this fibrous bundle of His, which divides into two bundle branches. And then the impulse spreads along these two bundle branches to quickly and synchronously activate both the ventricles. So you can see that sinus node problem or sinus node dysfunction will result in a problem with impulse generation. AV node disease or AV block, which can be either at the nodal level or below the node, will result is going to basically cause a problem for impulses to conduct from the atrium to the ventricle. Since the pulse is given rise to by ventricular contraction, anything which causes a fall in ventricular rate is going to present to you as bradycardia. What about sinus node disease? Now, worldwide, if you look at it, this is the most common indication for cardiac pacing. The important thing to remember about sinus node dysfunction is that it also involves abnormalities of the surrounding atrial tissue. That's a key thing to remember in mind. Now, generally, sinus node disease or even AV node disease for the most part is a degenerative disease of aging. But sinus node dysfunction can occasionally be encountered in younger people. So we should not be surprised. And there are some familial conditions which lead to sinus node dysfunction. And these are thought to involve defects at a molecular level. Now, as I said, sinus node disease involves atria. So what does this mean? The perisinus node tissue or even diffusely the atria can have areas of fibrosis and electrical disturbance. And this will sometimes paradoxically result in the occurrence of atrial arrhythmias as well. So in the same patient, you may have episodes of very low heart rate or sinus bradycardia. At the same time, you may also have other times episodes of atrial fibrillation or atrial arrhythmia. So this is the reason why this happens in sinus node dysfunction. What are the various ECG manifestations which you can come across? So at the very simple level is sinus bradycardia. And then you have little more advanced issues such as sinus arrest or cyanoatrial exit block. Then you have the so-called tachycardia syndrome, which we just discussed because of abnormalities of atrial tissue. And lastly, something called chronotropic incompetence. So when we look at sinus bradycardia, the impulses are all there, regularly occurring from the sinus node, but it is simply slower than normal. And this may not be adequate to meet the physiologic demands, which can lead to symptoms. The same concept can be extended a little further. The normal sinus node is going to give us the adequate heart rate response, whatever is required when we exert or perform some exertional work. But an incompetent sinus node may not be able to give us the adequate heart rate response. And this is known as chronotropic incompetence. Here it presents mainly with exertion or effort-related symptoms. Now, if you take it to the next level, you can have cyanoatrial exit block, where the impulses do originate from the sinus node, but they do not get through to the surrounding atrial tissue. And therefore, if the atria are not going to be depolarized, then there is no conduction. Or in the extreme form, you can have complete stoppage of impulses from the sinus node, which you call sinus arrest. Now, either of these phenomena will lead to these kind of pauses on the ECG, where you find that there is absolutely no P wave or no QRS. Or sometimes this kind of a failure of impulse from the sinus node can result in a junctional rhythm, where because the sinus impulse origin fails, the next level subsidiary pacemaker, which is the AV junction, that kind of takes over and that starts providing impulses. Now, junctional rhythm is an important entity to recognize. This is a condition where the impulse originates from the AV junction and transmits down to the ventricle, and it may also transmit backward to the atrium as well. And this is how junctional rhythm looks like on the ECG. You can see that there is a regular narrow QRS rhythm because the impulse is conducting to the ventricle along the usual infranodal conduction pathways, but there is no preceding P wave in front of the QRS. And sometimes you may find a retrograde inverted P wave when the junction transmits backward to the atrium. So when you find a slow rhythm like this with narrow regular QRS but no preceding P waves, you need to think of junctional rhythm. Many times I have seen clinicians confusing this with complete AV block. And as we will see later, to diagnose complete AV block, you need something a little different set of criteria. What about the clinical presentation of sinus node dysfunction? So you can obviously have dizziness or presyncope because of low heart rates. You can have palpitations either because of the feeling of a very slow heart rate or because of occurrence of tachyarrhythmias, atrial arrhythmias. Exercise intolerance would be a manifestation of sinus node dysfunction. Then you can also have sometimes heart failure because of this or systemic thromboembolic manifestations. Now, the evaluation of any arrhythmia, one of the problems is that the abnormalities can be intermittent. So the patient may not always have a low heart rate, but the problem can come and go, just like a faulty electrical wire, which is misfiring on and off. Therefore, an ECG is, of course, a basic investigation, but a single point ECG may not be sufficient for you to pick up the abnormality. Therefore, especially when patients have intermittent symptoms, you need a longer term monitoring, such as a Holter or a dement recorder, or even an implantable loop recorder where you insert a small device under the skin of the chest, which can record rhythm for a very long time. When you're suspecting chronotropic incompetence, sometimes it may be necessary to do an exercise testing, such as a treadmill test, to look at the heart rate response to exercise. Lastly, the question of an EP study. It is not a very high yield investigation as far as bradyarrhythmias is concerned, but occasionally it can be useful. So when do we need to treat? In sinus node dysfunction especially, symptoms are pretty important. If the problem is causing significant symptoms and causing a problem to the activities and lifestyle of the patient, we need to treat. But in any arrhythmia, it is important to rule out reversible causes before doing any intervention. For example, if there is uncorrected hypothyroidism, that can be very well responsible for a low heart rate, and therefore you need to treat the thyroid and not the heart. So the question which comes up in all bradyarrhythmias is, when do you take the decision to implant a pacemaker? So I think most of you will be familiar with a pacemaker, which is a device implanted under the skin, and then you have leads going into the heart, which provides an external source of current in order to overcome conduction disturbances. If you look at the indications for pacing in sinus node dysfunction, it is mostly related to low heart rate and symptoms. So there is symptomatic bradycardia or pauses, or there is chronotropic incompetence, or sometimes the bradycardia may even be due to drugs. But if the drug is really essential and cannot be stopped for the patient, then that also will constitute an indication for pacing. Let's look at AV block, the other major cause of bradycardia. Now, this is a delay or failure of conduction of impulses from the atrium to the ventricle. Now, this block can happen either at the AV node itself, or it can be in the infranodal His-Purkinje system. Both are given the name of AV block. And this can again happen in varying levels of severity. So you have first to third degree AV block. So in first degree AV block, you may be familiar that every atrial impulse or P wave is conducted to the ventricle, but it takes a longer time, which is reflected on the ECG by a prolonged PR interval. Normally, the PR interval is between 120 to 200 milliseconds. Here you can see it is exceeding that to 240 milliseconds. When you go to second degree AV block, some P waves fail to conduct to the QRS. Now, this is again divided into 2 degrees. One is Mobitz 1. Here, what happens is that you have basically the conduction being progressively more and more delayed. The PR gets prolonged, and then finally the beat gets stopped. Now, how to recognize this pattern quickly on the ECG? Often what you find in this Mobitz 1 or Wenckebach phenomenon is that the QRS tends to occur in groups. And this kind of group beating, if you see, you should think of Wenckebach. On the other hand, when you look at Mobitz 2 second degree AV block, the PR interval remains fixed, and then a P wave suddenly gets dropped. So there's a sudden random loss of AV conduction, which is a little more advanced form. There is another form of AV block, which is known as 2:1 AV block, where every other P wave is blocked and not conducted. One is conducted, the next one is blocked. Now, type 1 is generally considered, or Mobitz 1 is generally considered to be more benign, but it is controversial, and if there are significant symptoms, even that will end up requiring pacing. And Mobitz 2 is thought to convey greater risk and generally requires pacing. And lastly, you come to complete AV block, where you will see that none of the P waves are conducted to the ventricle. So how does the ventricular rate occur? It occurs because of something known as escape rhythm, which can come from any of the structures such as the His bundle or the distal conduction system or the ventricular myocardium. So typically the heart rate is low, especially the site of escape rhythm is very distal. The etiologies of AV block are many. Most common is the degenerative, the so-called Lev's or Lenegre's disease, then various infections, autoimmune conditions, then post-surgical AV block can happen. There are inherited conditions which can lead to it. And an important reversible cause of AV block is drugs. So the evaluation is similar to sinus node dysfunction. You may need longer term monitoring, and then you need to establish the diagnosis by looking at the rhythm and correlating it with the patient's symptoms. Now, there are a huge list of indications for pacing in AV block, but I will simplify it. Most of the times, third degree and morbid to second degree AV block will end up requiring pacing, even if there are no symptoms, mostly. Symptomatic Venki-back will also mostly end up requiring pacing. Similarly, first degree AV block, though generally not requiring pacing, if the PR is very prolonged, may require pacing if it has symptoms. And again, it's important to rule out reversible causes. So in summary, bradyarrhythmias, the clinical presentation and symptoms are very important, and we have to treat the entire clinical picture and not just the ECG. Now coming to tachyarrhythmias, we know that this is a situation where the heart rate is more than normal, more than 100 beats per minute. Again, an organized approach is very necessary. Let's quickly look at how we can classify it. Again, the clinical picture should never be forgotten. So there are various ways of classifying. The most common two ways which we use are one, based on the regularity of the rhythm, whether it's regular or irregular, and secondly, based on QRS duration. Now, if you look at it anatomically, then we can see which structure the tachyarrhythmia is arising from. If it is arising from anywhere above the AV junction, in this particular shaded area, then we call it a supraventricular tachycardia. If it arises from the ventricles below the AV junction, we call it ventricular tachycardia. SVT is usually a narrow QRS tachycardia, whereas VT is usually a broad QRS tachycardia, but there are some exceptions. So as far as the regularity is concerned, we are all familiar with the fact that a completely bizarre or irregular pattern usually indicates atrial fibrillation or a closely related arrhythmia known as MAT, multifocal atrial tachycardia. So this is a very familiar ECG of atrial fibrillation where you can see a very irregular QRS pattern. Now, sometimes you can have a regularly irregular. Similarly, we discussed with Venki-back, you can have this kind of a group beating pattern, which generally means some kind of an atrial tachycardia with a fixed block to the ventricle. Now, what about the narrow or broad QRS? The cutoff which we use on the ECG is 120 milliseconds of the QRS duration. If there is a narrow QRS tachycardia, it means that the impulses are conducting to the ventricle along the usual conduction system pathway, which is the very efficient way of conduction. But if the QRS is broad, it means that there is some disruption to the usual conduction. So in broad QRS tachycardia, there are really only three possibilities. It's either VT coming from the ventricular myocardium, it's SVT, but it's conducting with some aberrancy, such as a bundle branch block, or the last condition is something known as pre-excitation. So pre-excitation is a condition also known as WPW syndrome, where you have an accessory connection between the atrium and the ventricle. So it conducts through this pathway as well, leading to a bizarre and broad activation of the ventricle. And this can participate, this accessory pathway can participate in reentrant circuits where either it can participate in a reverse way from ventricle to atrium, or it can participate forward from atrium to ventricle. So if the atrium to ventricle conduction is via the accessory pathway, the QRS will be very broad and bizarre. Sometimes the pathway can also be a bystander. Here is an example where you have a very broad QRS, bizarre tachycardia, extremely fast, and the RR is irregular, which tells you that this is atrial fibrillation. But this bizarre QRS will tell you that instead of conducting by node, this atrial fibrillation is conducting via an accessory pathway to the ventricle. So to diagnose pre-excited tachycardias, the first question which we should look at the baseline ECG and see, is there pre-excitation on the ECG? How do you recognize that? The PR interval is very short because the accessory pathway is conducting very quickly, and you have this kind of a slur on the QRS, which is known as the delta wave. Then, if it is not a pre-excited tachycardia, the only two possibilities are it's either VT or SVT with aberrancy. Now, the clinical history is very important. If a patient has a previous MI or coronary artery disease or some scar in the ventricle due to surgery, most likely it's going to be VT. That is important to remember. As far as ECG clues are concerned, there are some key clues which you can pick up for VT. And that is because of the nature of the VT itself. See, in VT, in the ventricular myocardium, you are having an independent circuit running. The sinus rhythm is firing, but the VT is so fast that it cannot get through. The VT dominates. But occasionally, some interesting phenomena can happen. Sometimes you may see that occasionally one sinus beat is able to capture, and right in the middle of this broad Qrs tachycardia, you have a narrow beat. This is known as a capture beat, where the sinus managed to capture the ventricle. Or the sinus and VT may fuse to give an intermediate looking beat, which is known as a fusion beat. And lastly, because the atrial activity is running independent of the ventricular activity, you can have occasionally P waves which are coming on and off, which is AV dissociation. So these clues are important to look at the problem of VT. And also the QRS morphology, if you see, in SVT with aberrancy, the pattern will resemble usually a very typical bundle branch block pattern. Whereas in a VT, the QRS will look very bizarre and it will not fit into any bundle branch block pattern. Now, as far as narrow QRS tachycardia is concerned, a regular narrow QRS tachycardia is going to be SVT with very rare exceptions. There are common types of SVT such as AVNRT, AVRT, atrial tach, etc. We will not go into that, but this is how typically a SVT looks, a very regular narrow QRS tachycardia, and this is going to be a supraventricular tachycardia. One slightly different form is what is known as atrial flutter. Here, this is a big reentrant circuit in the atrium, and you can see these very classical sawtooth kind of atrial waves, which is conducting with variable block to the ventricle. And when you see this, you can recognize a atrial flutter. Now, we'll not go into these narrow QRS VTs. We'll just quickly touch upon lastly the management. One of the first questions when you see a tachycardia which comes to mind is, should we shock or should we not shock? Now, that basically depends on the hemodynamic stability. If any arrhythmia, no matter what your diagnosis is, causing hemodynamic instability, hypotension, or severe pulmonary edema, or severe angina, just get the patient out of the rhythm, do a cardioversion system. Then worry about what the diagnosis is. But on the other hand, if the VT is, if the VT or whatever rhythm it is stable, take the opportunity to quickly get a 12-lead ECG, which will be very valuable for diagnosis. Make a provisional diagnosis and then go ahead with the definitive management. To manage SVTs, certain vagal maneuvers like carotid massage, etc., are very useful. The drugs which are used are usually IV adenosine or verapamil. And in long-term management, you can use drugs such as beta blockers, calcium channel blockers, etc. You can also think of curative procedure like catheter ablation, where the axillary pathway can be ablated by doing an interventional procedure for long term. Again, for VTs, the drugs which are useful are amiodarone and lidocaine commonly. For a particular condition known as polymorphic VT or tossards, IV magnesium is very helpful. It's important to identify and treat any precipitating factors. And lastly, the ICD or implantable defibrillator can be useful in those patients where the long-term prognosis is thought of the VT can recur. So with this broad overview, I will stop, and I'll be happy to take any questions or comments.
Thank you so much, Dr. Narayanan. Matters of heart are always complicated. Thank you for simplifying that, I would say that. And we are really privileged, as I mentioned, and we have already received some comments and some feedback that this is an excellent session on arrhythmias. And there are a lot of questions that have come up. What I'll do is I'll directly go to the doctors who have questions, and they will definitely come up, ask the questions. So I've already unmuted Dr. Lele. He has 2 questions, and he was the first one to raise. So Dr. Lele, you can unmute yourself and probably ask the questions yourself. I would prefer that.
Yeah. So I have occasionally come across people who are asymptomatic, but have occasional VP beats, atrial arrhythmias, or left or right bundle branch blocks. In such a case, what to do? The reason is, do we subject them to intensive investigations or we leave them alone?
Right. So there are 2 to 3 different things here. So generally, as I said, in treating arrhythmias, symptoms are pretty important. So most of the time, we'll be intensively investigating or treating arrhythmias if they are symptomatic. But there are few exceptions to that. One, as I touched upon, are advanced grades of AV block. Now, if someone has advanced 2nd degree or 3rd degree AV block, even if they are asymptomatic, we generally end up pacing simply because we know that the natural history of this condition is not good, that there is a risk of cardiac events in the long run. But on the other hand, if there is something just like a simple bundle branch block or occasional premature ventricular beats with no other symptoms or no other problems, such patients we may choose to conservatively follow up and just keep following them up to see if any other problems are coming up or not. I do have a number of patients like that on follow-up under me.
The problem is when you tell them that they are having some kind of a problem, they start getting worried.
Very true. That is true. And that is why
because it could be simple occasional ventricular beat, or even this bundle branch block. The moment they read the ECG report, then they start wondering what to do, because these reports are available to them now after they are done.
Very true. And it's very true that I think part of our job in any field, and again true in arrhythmias, involves spending some time with the patient and reassuring them whenever it is genuinely nothing to worry about at this point of time. And some of them, I end up telling many of them nowadays, thanks to availability of some sensors and pulse oximeters and all, they also get into the habit of excessively monitoring their heart rate and getting panicked because of that. So some of them I end up telling them, please put away your sensors, put away your Fitbits, and just go ahead and lead a normal life. And your body will warn you. It will give you symptoms if at all anything is coming up in the future. So that's one way I explain to them. So I agree that sometimes because some label has been given to them, they do get very anxious, and we need to kind of reassure them, saying that some of these are physiological variations, or they are not that frequent, so you don't need to kind of get worried about it.
Great. Thank you so much, Dr. Lele, and thank you, Dr. Narayanan, for taking up the question. Dr. Lele, I think both the questions are answered, right? Okay, perfect. So I had one raised hand, and I will switch to the person, to the doctor. Yeah. Yes, Dr. Manjula Shri. Dr. Manjula Shri, you can unmute, please. Yes, and ask your question. Dr. Manjula Shri, if you're able to hear me, you can unmute and ask your question, please. Meanwhile, we can take up a question from Dr. Madhuri Devsigda. Dr. Madhuri also can unmute. And but he has asked, could you guide on CPR in a patient on a pacemaker?
Hello, Dr. Madhuri here.
Yes, Dr. Madhuri, please.
Can you hear me?
Yes, Dr. Madhuri, we can hear you very well.
Yes, it was a wonderful session, I should say, very, very nicely explained and simplified, and explained so well, which will really help us in our day-to-day practice. My question is, could you please guide us on a few CPR techniques in a patient who is already on a pacemaker?
Right. So that's a very good question. So we need to understand that a pacemaker can pace the heart as long as the problem is only confined to the conduction system and the rest of the myocardium of the heart is normal. So, sometimes lay people will tell us that, oh, does a pacemaker make you immortal? That means you can never die. Unfortunately, that's not true, because once any disease becomes severe enough to lead to a cardiac arrest, what happens is that the myocardium also stops responding. So even if you electrically stimulate it, it is not going to respond. So when patients with pacemakers eventually expire due to whatever cause, what you will see on the ECGs, you will just see the pacemaker spikes, but there will be no capture of the QRS. So when a patient with a pacemaker or other cardiac device has a cardiac arrest due to whatever cause, the CPR has to follow absolutely the same guidelines as you would do for any other patient. Now, as far as the concern of mechanical trauma due to CPR to the devices, the risk is minimal, because generally the pacemaker or device is off to one side. It is under the left or the right infraclavicular area. your CPR is pretty much going to be central. So the risk of damage is less. But even if there is some risk of damage, we should not be concerned about it at that point of time, because what is going to immediately save the life of the patient is the CPR. If there is any damage to device or leads, it can always be addressed later, and that can be taken care of. So we should just follow the same guidelines and do CPR as we would do for any other patient.
Great.
Thank
you so much. Yeah, that's
so
nice. Yeah. We go to Dr. Thyagaraja and then to our president, Dr. Gajendra Kumar. But Dr. If at all Dr. Manjula Shri is able to unmute, if you can definitely, in the meanwhile, if you are able to unmute, because you had a question and you tried to unmute, but you were not able to ask. Dr. Manjula Shri. So in case you are able to ask your question now. Okay. Fine then. We park it there. We go to Dr. Thyagaraja. Please, Dr. Thyagaraja, over to you. You can unmute and please go ahead.
Hello.
Yes.
Dr. Pawan Kumar Gupta, can you hear me?
Very well, Dr. Thyagaraja.
Okay.
Loud and clear, and we can see you also.
Okay. Thank you, sir. Thank you very much. Very nice lecture, sir. It is one of the proud moment for us that cardiac cases has been involved in our webinar. The best lecture which we have come across. Very nicely explained, sir, about arrhythmias and its complication, how to handle these arrhythmias and how to diagnose this electrocardiography. Sir, I have one simple question. Sir, whenever these arrhythmias come, how the cardiologist will manage, or how electrophysiologist will manage this case, sir? Is there any differentiation when they look in the pathology or the clinical manifestation, or how to management these things in the an electrophysiologist and a cardiologist, how they distinguish these things between these arrhythmias, sir?
Right. So great question. And, you know, as far as the medical management of arrhythmias is concerned, especially in an emergency, I don't think there should be any distinction between a cardiologist, electrophysiologist, or even a physician for that matter. Because for the immediate management of arrhythmias, everybody needs to have the basic knowledge. Now, an electrophysiologist's role mainly comes in two ways. Number one, if you want to plan some kind of an interventional curative procedure, such as catheter ablation of arrhythmias, that is something which we are doing very much on a regular basis now, because many of the SVTs, for example, supraventricular tachycardias, are because of distinct focal pathways within the heart. And if we can just put a catheter there and ablate that pathway, just very focally and precisely, we can cure the patient of that arrhythmia for life. And there are many arrhythmias which are amenable to such a curative therapy, and that is one thing. Similarly, in treating bradyarrhythmias or certain aspects of heart failure, you can use devices such as pacemakers or defibrillators, implantable defibrillators, or something called cardiac resynchronization therapy. So all of these advanced types of pacemakers. So whenever that kind of a little advanced intervention is needed, the electrophysiologist like me has an important role. The second would be in kind of analyzing complex arrhythmias. So as I said, when we are faced with an emergency and if there is hemodynamic instability, then we should not worry too much about the complicated diagnosis. We should do what is necessary to stabilize the patient. But later, after that, the next step when it comes, especially in analyzing some complex arrhythmias or complex interplay of factors and trying to find out how to prevent this recurrence, how to best manage for the future, what best antiarrhythmic agents to use. Here is again a second place where the expertise of the electrophysiologist can come in. So I think these are the two areas where you can say there is a need for the electrophysiologist.
Thank you very much, sir.
Thank you. Thank you, Dr. Thyagaraja and Dr. Narayanan. Once again, over to our president, Dr. Gajendra Kumar.
First of all, my compliment, Dr. Kumar Narayanan, for a wonderful presentation on the subject. And you have really simplified the things for especially the general physicians. Now, my specific question is, in which type of arrhythmias normally the radioablation is used as a mode of treatment, and is the radioablation give curative? It is a curative treatment, or there are chances of recurrence?
Right. Wonderful question. So, radiofrequency catheter ablation as a therapy for arrhythmias has been available for about 2 decades. So in essence, the principle is you do a minimally invasive procedure similar to a coronary angiogram. You put some electrode-based catheters into the heart so that you can map the electrical signals, you can identify the arrhythmia, and then you deliver a little bit of radio frequency energy at a very focal spot to ablate the critical circuit which is sustaining the arrhythmia. And if you're able to do that, then theoretically you can cure the arrhythmia. Now, the point is that not all arrhythmias are very suitable for catheter ablation. So there are certain arrhythmias which are extremely suited for catheter ablation with very high success rates. These are typically the SVTs, the supraventricular tachycardias, including the common form of atrial flutter, as well as certain idiopathic ventricular arrhythmias, by which we mean that there is some VT, but there is no associated structural heart disease like ischemic heart disease or some complex cardiomyopathy, where the heart is otherwise normal and you simply have an abnormal focus firing in the ventricle, due to which you have a VT. So these kind of clean focal arrhythmias are very amenable to catheter ablation. And here the success rates are typically 90% or more, which means the chances of recurrence are under 10%. And for SVTs, it's typically about 99%. So once we ablate an SVT, the chances of recurrence are very low. But for other complex arrhythmias like atrial fibrillation, which is a very complex multifocal arrhythmia from the atrium, there is no single focus. Or for complex VTs arising in structurally abnormal hearts like ischemic heart disease and scarred ventricles, there the success rates are not very high. We do use catheter ablation in those situations also, typically as a second line therapy when drugs have not given a satisfactory response. But here the success rates are more like 70 to 75%. So we need to counsel the patient that there is some risk of recurrence in such situations.
Thank you.
Thank you so much. A question, Dr. Kishore Parikh definitely raised hand, but I could see that hand is already lowered. So in case Dr. Parikh, you would like to ask question, then you can once again. But Dr. Narayanan, I think this is wonderful. I have two quick questions. And this is why we kept this time for Q&A, because this I feel is very important and reciprocating. In COVID, this is related to current pandemic situation. In COVID patient, most of the COVID patient, it has been observed that pulse was higher. They used to measure it on the pulse oximeter. Was there any specific reason? It was mostly in tachycardia range, above 100 most of the time. But patients were normal. I mean, these COVID patients were not showing any sign of cardiac related illness, I would say, or cardiac complications. But pulse was high always. And many people got worried about it. And then it was always told that nothing to worry, this is being observed. But then from an expert like you, I would like to have some opinion on this, please.
Right. In fact, I had planned to talk briefly on COVID and arrhythmias, but due to time constraint, I couldn't do that. So COVID has been related to different types of cardiac arrhythmias over the last 1.5 years that we are seeing it, and the knowledge is still evolving. But the commonest so-called arrhythmia, which you can see, is simply a sinus tachycardia. And this is not necessarily specific to COVID. And many times due to any illness or fever or stress or anxiety, the first thing which anybody is going to have is a little increase in the heart rate, which is sinus tachycardia. Yeah. And unfortunately, over the last 1.5 years, COVID has become like a little bit like a kind of stigma. Even if people have mild disease, they are really scared once they are given the diagnosis of COVID, and they keep on monitoring themselves. So that is the commonest reason why simple sinus tachycardia happens. And often it is not really anything to worry about. And once the illness and anxiety settles, it kind of settles by itself.
But any long-term impact on heart because of this 15-20 days of higher pulse rate? Because it is prolonged. It will at least observed for 15, 20 or 25 days even.
Right. Now, if there is a persistent increase in heart rate, especially something which is causing symptoms such as palpitations, then the first thing we need to do is to make sure that it's not something other than sinus tachycardia. It's not one of the other arrhythmias, because COVID has been related to many other kinds of arrhythmias as well, such as atrial arrhythmias, even bradyarrhythmias such as sinus bradycardia, AV block, etc. But unusually, and very rarely serious arrhythmias like VT, etc. So the first step would be to clarify the diagnosis. And if it is simply sinus tachycardia, then generally we don't expect any long-term impact. If it is one of the other arrhythmias, then it has to be identified and treated.
Thank you so much for elaborating on this. We have a question from Dr. Sushma Trivedi, very esteemed member of our society and our organization. And she has asked, throw some light on CPR in COVID, in this COVID pandemic, like in sudden collapse patient in a COVID patient. So how to go about CPR?
Right. Again, a very good question. And in fact, this has been some subject of the research I've been involved in over the last 1.5 years. Through my collaboration with Paris, we looked at the incidence of sudden cardiac arrest, which has happened during this COVID pandemic. And unfortunately, this COVID pandemic has had some serious repercussions on cardiac health. So we found when we looked at the area of Paris that there was almost a doubling of the incidence of sudden cardiac arrest during this time. And the reasons are multifactorial. People are scared to come to the hospital. Their routine cardiac care gets neglected. For other emergencies, they get worried and they don't come to the hospital. But it's important to know that even despite the pandemic, as far as possible, we should try to follow the same guidelines for CPR as we are following for anyone else. The obvious problem comes because, if you're not having PPE, you feel hesitant to go and give the, cardiac massage and all those. And an important relevant thing to remember is that as per latest CPR guidelines, this need for giving artificial respiration or mouth-to-mouth breathing is not mandatory. That is especially difficult for many people, especially if you are having an infectious situation like this.
Correct.
So what you can do is just give hands-only CPR, just give cardiac massage, and many times that is enough to save the life. Even if you don't give any mouth-to-mouth resuscitation or any artificial ventilation. So just try to give while keeping a mask, while keeping a double mask if possible, just try to give the hands-only CPR, and that may be enough for you to save the life.
I think that's really wonderful throwing light on this question because, most of the time people have been perplexed about this perspective and more information needs to be percolated. Let's see how we are able to help. We have a raised hand by Dr. Kishore Parikh, and that would be the last question probably of the session. Dr. Kishore Parikh, please request you to unmute and ask question, Dr. Parikh.
Hello. Am I audible?
Yes, Dr. Parikh, we can hear you. Yes, please.
Yes, sir. It was very wonderful presentation.
Thank you.
Sir, my question is, we are occupational health physicians and we have to come across the different pre-employment medical checkups and particularly the ECG findings. So we see many times left bundle branch as well as the right bundle branch findings in the ECG. So can you, sir, please highlight about the fitness of that employee, particularly for the heavy work?
Right. So bundle branch blocks, as you say, you can come across them once in a while. Now, the right bundle branch block is generally a more benign finding, and in some patients it can be what we call a normal variation. For some reason, there is a little bit of slowing of the right bundle branch conduction. So that could be a physiologic variation also. The left bundle branch block is usually pathological. But sometimes the ECG manifestation could be early and the actual pathology may evolve later over time. Now, irrespective of whatever the thing, what I would suggest is if you find a bundle branch block in an otherwise asymptomatic patient, it's safer to do a basic cardiac evaluation, including a thorough history and examination, as well as a basic imaging like a 2D echocardiogram, which may pick up some silent and unsuspected cardiac lesion. Now, if all of the workup is normal, and especially if it's just an asymptomatic right bundle branch block, I would say there is no contraindication to fitness even for heavy work. For left bundle branch block, I would probably be cautious and have a discussion with the particular patient and then advise them to see if they could potentially go for not a very strenuous work if possible, because generally LBBB, there is going to be popping up in the future.
We are losing your voice, Dr. Narayanan. I think there's some network glitch. Yes.
Yeah.
Okay. Yeah, that's fine. Dr. Parikh, I hope
answered.
Yeah.
Thank
okay.
you.
Thank you so much. I have many more questions, and there are, so Dr. Narayanan, we will stop here we'll stop the Q&A session here, and we will post some questions in the chat box. In case you have some time, you can please, if you can answer them, it will be really grateful.
Sure.
If you have some time to hand. And with those words, we are really grateful to you for sparing your time this evening and answering and taking this question and throwing some light on this arrhythmias. We have the recording of this session, and people would refer to it. It will be posted on our digital media platforms, and there are like thousands of physicians who would probably look at it in due course of time. Thank you once again for your time.
Thank you very much, and it was my pleasure to participate. Thank you.
Thank you.
With that, we move on to our awaited session on EPID updates from none other than our very own Senior Vice President, Dr. Rajiv Kumar Jain, sir. Dr. Jain, hope you are able to hear us. And if I may request you to please switch on your camera so that we can see you.
Is visible?
Yes. Oh, yes. Okay. Thank you so much, Dr. Jain. Well, before I hand over this dais to Dr. Jain, a brief introduction of Dr. Rajiv Kumar Jain, who is Senior Vice President, AUHD, and Senior Consultant, Health, Indian Railways, New Delhi, with 40 years of experience in health and hospital administration, Fellow Award of Indian Public Health Association, Fellow Award of Association of Environmental and Occupational Health, Delhi, published and presented more than 145 scientific papers in national, international conferences and journals and books, fellowships, scholarships by World Health Organization, National Institutes of Health, National Institute of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. As I always say, the list is quite long, but these are the few ones in the initial order that I would always like to read, and in some time I think I'll be able to remember all of them. And I will, without looking at the screen, I will be able to tell. Thank you so much, Dr. Jain, for sparing your time once again this fine evening, and we look forward to the EPID updates. Over to you. This dais is all yours.
Thank you, Dr. Pavan.
Thank you,
so friends, today again, after 7 days, we have gathered here. Apart from the regular clinical session, we review the epidemiological situation of the COVID-19 pandemic. As you know, COVID-19 pandemic has been going on in the world for the last more than 1.5 years. We every month review the situation of COVID-19 epidemiology across the world, in the region, and in India, and in the states and districts in the country. And if we have to review the situation, we review the situation in terms of cases, deaths, test positivity rates, and vaccination. Those are the few areas that we cover. And we also cover the current epidemiology of the genomic analysis of COVID-19 virus, how smart the virus is becoming every day. That is visible through genomic analysis for the last now more than 6 months. Genomic analysis throwing new lights. Alpha, beta, gamma, and all kinds of alphabets are being devised every month across the world, and how the previous strain is now getting spread in more countries. So let's begin epidemiological update of COVID-19 today. Next slide, please. This is the situation of COVID-19 cases reported by World Health Organization regions and the global deaths. If you look at the colors, if color coding is available on the left top, and if you look at the graph, the black line is the deaths and the graph in color is the cases. So you can easily imagine how dominant the Americas are still in the world. Americas means South America and North America. But predominantly now it is South America, which is shown in yellow. But Southeast Asia is now coming down, but it is substantial if you look at the world proportion today. If you look at the graph, green portion, that is Europe, is still not out of the woods. And if you look at the graphs of each country, there are waves and waves and waves. So there are waves of deaths and there are waves of cases. And also if you look at the way things are happening, if we are not yet out of the woods in the world. You will see the specific situation in the next slide. This is the slide in numbers. If you look at the column on change in new cases in the last 7 days, you find negatives and numbers without positives or negatives. They are the area of attention. If you look at Africa, the change in new cases has been 39% increase. If you look at Southeast Asia, there is 21% decrease. And if you look at global, it is only 6% decrease. So it's going down in one region and it's going up in other region. Europe, only minus 6% decrease. And if you look at the Americas, it is 0%. 0% is the decrease. There is no increase, there is no decrease. What is happening? One country coming down, other country going up. So net result is 0%. If you look at the column on the right side, change in new deaths in the last 7 days, 38% increase in deaths in Africa. 38% increase in Africa. And Eastern Mediterranean, 2% increase. On the other hand, 26% decrease in deaths in Southeast Asia and 9% decrease in Western Pacific, and in Americas only minus 4% decrease. And in Europe, it is only minus 12% decrease overall, which is the global average is minus 12% decrease in number of deaths. So the pandemic in the world is very much there, and you need to still keep up your guards. Travel, international travel specifically, shall remain restricted for reasonable future. Next slide, please. This is the coronavirus disease, that is COVID-19 dashboard of the World Health Organization. And this is a snapshot of the 6 regions of the world in the WHO. If you look at the last 24 hours, on the second column, which is cases newly reported in the last 24 hours, Americas are by far the most dominant region. If the total figure was 437,000 in the world, 50% cases were from Americas, 215,880. 81,000 cases were from Southeast Asia region where India is situated. 57,000 were from Europe and 34,000 from Eastern Mediterranean region. Africa has a very high figure of 30,513 and Western Pacific is the lowest with 18,000 cases. If you look at the deaths, also out of 9,000 deaths, if you look at the figure, 5,000 deaths have occurred in America, mainly South America, and 1,930 in Southeast Asia. So we can say the pandemic epicenter these days is in Americas, especially South America. Next slide, please. Now we come to the countries. Instead of regions, we are going deeper. The countries. Cases newly reported in last 24 hours across the world was 437,000, out of which 115,000 were reported from Brazil, 51,667 from India. India is still the world's second highest reporting country in terms of cases in 24 hours. Again, South America, Colombia, 29,995, Argentina, South America, 27,319, Russian Federation, 20,393, Indonesia, which is Southeast Asia region, 18,872, United Kingdom in Europe, it's 16,700, South Africa in Africa, 16,078, United States of America in Americas, 14,239, and Iran 11,734. That is Eastern Mediterranean region of the WHO. So all the countries in the top 10, if you see, are reporting more than 10,000 cases in 24 hours. If you look at the deaths, next slide, please. These are the deaths, 9,218 total deaths reported across the world in last 24 hours. 2,392 deaths were reported by Brazil only. So more than 40% deaths or more than 25% deaths in the world have been reported by Brazil. India reported 1,329, Argentina 705, Colombia 645, Russian Federation 601, Indonesia 422, United States of America 355, Mexico 342, Peru 167, and South Africa 148. So you find predominantly in the countries in deaths, it is South America, and also you find Southeast Asia, you find Africa, and you find Europe. So no continent is still untouched in terms of deaths. All are reporting around more than 150 deaths in 24 hours. Next slide, please. Now we come to India. After having seen the WHO regions and the countries of the world, we come to India. 48,768 new cases, 1,183 deaths, and 20.5 lakh tests done yesterday. 7-day average test positivity rate has come down to 2.9%. 5.9 lakh active cases are there. They are shrinking by -3.4%. Total 3.02 crore cases and 3,94,525 deaths reported officially. So we are inching towards 4 lakh deaths in India. 31.5 crore vaccination doses have been given. 61.2 lakh were given yesterday. Next slide, please. This is very important slide because this shows the entire reality of the diversity of India. If you look at the blue column on the left of confirmed cases out of 48,000, Kerala is still at the top with 11,546. It is never coming down less than 10,000. And Maharashtra again is at the top second, 9,604. And this is the area of concern. Kerala and Maharashtra are going up again. Tamil Nadu is 5,755, Andhra Pradesh 4,458, Karnataka 3,310, Odisha 2,912, Assam 2,793. These are all states which are reporting more than 2,000 cases in the last 24 hours. If you look at the deaths, Maharashtra is still at the top with 511 deaths in last 24 hours. Tamil Nadu with 150, Kerala with 118, Karnataka with 114, Andhra with 38, and Odisha with 40. While West Bengal is 35. These are the top 6 states with reporting highest number of deaths. So it is the deaths and infection is predominantly in southern India. If you look at the states, all southern Indian states, Kerala, Karnataka, Andhra Pradesh, and Tamil Nadu are all there in the top. If you look at the tests per million per day, if you look at the bottom, my attention and your attention I would like to draw would be on the bottom. Nagaland, Rajasthan, West Bengal, Madhya Pradesh, Bihar, and Chhattisgarh are testing very little number of tests per million per day. And these are states which have, if you choose, which you will see, they require more testing and more testing. 7-day average test positivity rate, if you look at the Indian average is 2.9, but what is happening in Northeast? Sikkim, 15.6, Manipur, 12.4, Mizoram, 12.1, Meghalaya, 11.1, Kerala, 10.4, Nagaland, 9.6, Goa, 7.6, Andhra Pradesh, 5.4. So what do we learn? Northeastern states have more transmission of infection, and also Kerala and Goa are coming back in terms of infection. 7-day average daily growth, Indian average is 0.17%, and again daily growth is maximum in northeastern states. Top is Mizoram, Meghalaya 0.97, Manipur 0.84, Arunachal 0.76, Tripura 0.58, Assam 0.57, Sikkim 0.56. So Northeast now is showing daily average growth highest in India. All the northeastern states, without exception, and maximum has been in Mizoram. So need to investigate deeper and to have very urgent emergency containment measures in the northeastern states and especially Mizoram. If you look at the vaccinated persons with at least one dose in percentage, bottom again is important because we need to garner our resources for improving vaccination in these states. These states are from the bottom are Bihar, Uttar Pradesh, Jharkhand, Tamil Nadu, and Assam. These are the 5 states which we must focus our attention because Indian average is 22.58%, Bihar is only 12.43, Uttar Pradesh 12.55, Jharkhand is 16.59, Tamil Nadu is 18.6, and Assam is 18.78. So these states need to ramp up very vigorously the vaccination. Delhi, fortunately, is amongst the top. Delhi is 38.06%, while Indian average is 22.58%. Let's go deeper and see the genealogy of the COVID-19 virus. Now it is taking many shapes and many colors, giving rise to variants of concern and variants of interest. And look at the alphabets, Latin alphabets, alpha, beta, gamma, delta, and epsilon, zeta, eta, theta, iota, kappa, and lambda. Look at the difficulty we have in remembering the variants of concern as well as variants of interest. So this table gives you a snapshot of the GSH clade, the next strain clade, our earliest documented samples, and date of designation. If you look at the right column, date of designation, the last one is important. On 11th May, Delta variant B16172 was declared a variant of concern. And if you look at the variants of interest, on 14 June 2021, Lambda C37 was declared variant of interest by the World Health Organization. But also, if you look at Kappa, that is on 4th April 2021 in India, which is B16171, was also declared. Also, we have now Delta Plus strain. We will talk about it in more details in subsequent slides. Next slide, please. This is an important picture or the map of the world, the 4 maps in different colors. The top left map is for the alpha variant in 170 countries. And beta in blue on the top right is in 119 countries in the world as on date. Gamma variant, which is in brown left bottom, is in 71 countries at the moment. And last but not the least, the most important variant, that is Delta variant, is now in 85 countries. And you, besides the purple color, you find yellow color is also there. That shows lineage is not specified in 9 countries. So what do we learn? The virus in different forms is lurking all varieties in India, number 1, and all varieties in South America, and all varieties in Europe, and all varieties in Northern America. So we must understand the virus is becoming smarter every day, and it's spreading the smartness across the world, across the countries, and across continents very, very fast. This is a summary of the phenotypic impacts of variants of concern, which is alpha, beta, gamma, and delta. In terms of transmissibility, we find delta has increased transmissibility and secondary attack rate. Disease severity in Delta is not confirmed. Possible increased risk of hospitalization. Risk of reinfection in Delta, reduction in neutralizing activity has been reported. Impact on diagnostics, none reported to date for Delta. Impact on vaccine efficacy and effectiveness, protection retained against severe disease, possible reduced protection against disease and infection, limited evidence on only 2 vaccines. That is severe disease, no or minimal loss for Pfizer-BioNTech vaccine, and symptomatic disease, no or minimal to modest loss with Pfizer and AstraZeneca. If for infection, no or minimal moderate loss for AstraZeneca and Pfizer-BioNTech, which is AstraZeneca is Covishield in India. So there is impact is visible now through studies published and accepted by World Health Organization. If we look at impacts on neutralization for full vaccination by vaccine, for Delta, it is no or minimal loss for Bharat Covaxin, no or minimal to moderate loss in Pfizer-BioNTech and Bharat Covaxin, and substantial loss in single dose of AstraZeneca vaccine, which is Covishield in India. So this is a snapshot of all the 4 variants across the world. Next slide, please. This is again a very important picture to show you how rich countries are definitely much far ahead compared to the poor when it comes to the percentage of their population getting at least single dose of COVID-19 vaccine. But India does have an advantage over many of its counterparts among lower middle income countries. The top cluster is of high income countries led by US and also Australia. Are the size of the circle shows the higher level of vaccination. If we look at Canada and Chile and Australia are marked in the top cluster, upper high income countries. Next cluster is of upper middle countries. Upper middle countries you find is led by China, Brazil, Indonesia are the large clusters, large size circles. But I would like your attention to be drawn to lower middle income countries, the third cluster from the top, led by India. And low income countries are led by the bottom cluster, are led by Ethiopia. The circle size is proportion to the its population size. So you find now the 3 clusters: income, upper mid is China, lower mid is India, and low income is Ethiopia. So this is the disparity chart. Huge disparities amongst countries, and the rich countries are concentrating, have larger scope, but amongst the upper middle and lower middle also there are huge disparities. And that is why we need to understand, unless all the countries are protected, nobody is protected, because it's a pandemic. Next slide, please. Now we discuss the figures for the districts and what is happening in India. Since the onset of the second wave of the COVID-19 pandemic, about 3 months ago, 1 or more of the 10 states leading in new cases had been reporting an increase in weekly deaths. Last week was the first time that all 10 states reported a decline in weekly deaths. On 23rd of June, the 7-day average of all India reported deaths was 1,440. This is down 68% from the peak of 4,529 on 18th of May. A week ago, this number was 2,329. At the same time, several news reports point to a massive undercounting of COVID-19 deaths by state administrations. These reports use civil registration data on deaths to compute the variance between the number of deaths in COVID months and in the corresponding pre-COVID period. The difference is excess deaths, much of which is likely because of COVID-19, but not recognized as such by the local administration. For 8 months for which such an exercise was done, the cumulative excess deaths are 10.5 times the reported COVID-19 deaths. Please mark this figure. The excess deaths are 10.5 times the reported COVID-19 deaths. This acquires additional significance as the country's highest court, that is Supreme Court, is hearing a petition that wants the government to pay 4 lakh rupees each to families of those who died because of COVID-19. The center has replied that neither it nor the states have the funds to do so. 15,680 crore rupees for the reported 3,92,000 deaths. 15,680 crore is required to be given as ex gratia. If the court directs such a payment, it would nudge families to pursue correction in official records. This would reveal COVID-19 death numbers that are closer to the real toll, while complicating the government's fiscal mathematics. This is an important development of this week. Next slide, please. All 10 states, as I said, leading in new cases are reported weekly fall in deaths. If you look at the graph on the left side, you will realize cumulative excess deaths across 8 states, that is Uttar Pradesh, Madhya Pradesh, Tamil Nadu, Andhra Pradesh, Karnataka, Bihar, Gujarat, Assam, and Kerala. Next slide, please. The declining trend, all Tirunelveli district reported above 10,000 new cases, on all others are reporting less than 10,000 cases in this month. Next slide, please. China has been gaining. India climbed a spot. Earlier last week we saw India was 5th in terms of weekly growth in vaccinations, and now India is number 4. This is behind Japan, 24%, Philippines 19%, China 13%, India is 12%. And among the 10 most populous countries, the US leads in COVID-19 vaccine coverage. That is 95.5 vaccination per 100 people. The world's largest economy has already given 95 vaccine doses per 100 population. China, the second largest economy, increased its vaccine coverage from 56.2 per 100 population last week to 74.5 this week, according to our world data. With 1.09 billion doses, the world's most populous nation has now given more doses than Europe, North America, and South America combined. However, only about 15% of its 1.43 billion population is fully vaccinated. About India, registered 12% growth in coverage. It climbed a spot to 4th in the growth. At its current pace of 4.7 million doses a day, India will take a little more than 4 months to hit 920 million doses, the equivalent of its population. Next slide, please. As all states cost 10% in total vaccine per capita. So that is a good thing. Next slide, please. New threat of Delta Plus is there. And the infections have also been reported from Nepal, Portugal, Switzerland, Poland, Japan, Russia, Turkey, US, France, US, and Canada. As on date, 48 cases of Delta Plus have been reported from India. US is highest, 83. Next slide, please. Why is Delta Plus variant another cause for worry? Next slide, please. What is Delta Plus variant? Not much is known about this new variant, and health experts are worried. It is a version of the prevalent Delta variant, which had a huge role to play in the country's second COVID-19 wave. Health authorities here have termed the Delta Plus B161721 a variant of concern. However, globally, experts have still not shown any confidence in this concern. The variant is said to be highly transmissible, and some fear that it can lead to a third wave in the country. Symptoms for this variant include dry cough, diarrhea, fever, headache, skin rash, discoloration of fingers and toes, chest pain, and shortness of breath, among others. What is the cause for concern? Delta Plus has the same mutation that was first seen in the Beta variant in South Africa. It is also a version of its predecessor, that is Delta, that is first found in India, and therefore has all its characteristics. The combination of South Africa and Indian wave. This combination can make it all the more transmissible. Indian SARS-CoV-2 Genomic Consortia is studying the transmissibility of this variant and is likely to release a genomic surveillance bulletin soon. The health ministry says this variant binds more easily to lung cells and is potentially resistant to monoclonal antibody therapy. There is also no data on how existing treatments or even vaccines will work against this. Next slide, please. Where has this variant been detected so far? As on 23rd June, 40 samples from 3 states have been detected with Delta Plus, with Maharashtra reporting largest share. Delta Plus infections have also been reported from Nepal, Portugal, Switzerland, Poland, Japan, Russia, Turkey, UK, France, US, and Canada. No deaths have been reported among the UK and Indian cases. Can it really lead to a third wave in India? Yes. The health minister has warned that region where the wave has been found may need to enhance their public health response by focusing on testing, quick contact tracing, and priority vaccination.
Okay.
According to an ICMR scientist, while the variant alone cannot lead to a third wave, it can be finishing. This is the last.
Thank you. Sure.
Ultimately, the possibility of a third wave depends on how strictly the public follows COVID guidelines. We will know more once enough samples have been genome sequenced in India. What is the center doing about it? The health ministry has advised the chief secretaries of Kerala, Maharashtra, Madhya Pradesh, and also Haryana and Punjab, the 5 states actually, where Delta Plus has been detected, to take up immediate containment measures in the districts and clusters, including preventing crowds and intermingling of people, widespread testing, prompt tracing, as well as vaccine coverage on a priority basis. ICMR and the National Institute of Virology are in talks to conduct a study to see if variant can be neutralized by Covaxin and Covishield. So this in nutshell is the summary of the epidemiological situation of COVID-19 in India as on date.
Thank you so much, sir. That was illuminating and quite elaborate, and also most pertinent when it comes to Delta variant. We really appreciate your kind gesture for collating all this and sharing with us. Without any delay, I would immediately request take it to Dr. Sandeep Sharma for his comments, questions, and also his feedback. Please, Dr. Sharma.
Thank you, Dr. Pawan.
Thank you.
Yeah, this Delta variant, now Delta Plus is a variant of concern right now, and now in just 1 week, from 3 states, now it has gone to 11 states, and maximum cases are there in Maharashtra. So everyone is worried about this particular variant. Even organizations, they have now started taking more of the steps, and as advised by Government of India, the travels have been now restricted because everyone was thinking that we should now start opening up in view of this control in the second wave of the COVID. But the particular Delta variant, now it has given a lot of insight that we still have to hold at least for 6 weeks minimum, because genomic studies, they have revealed that maximum cases which have been sent for this genomic testing, they are of Delta Plus. So we all have to be very careful, and what we see in the markets and the outside world, everyone is now trying to move out and enjoy the liberties, but still we have to be very careful. And second, this treatment part also, like the COVID care preparations which organizations they were doing earlier, they need to still to continue with all those preparations, and they need to still maintain these oxygen beds and the testing facilities, rapid antigen test, wherever these numbers are high, or wherever this Delta Plus variants they are there, or number of cases they are detected, then immediately they should go for rapid antigen testing. or rapid antigen screening of this. So yes, here Dr. Rajiv Jain sir, he has covered a widely about this whole issue, and it is still not the time to relax. That is what I would like to tell everyone. Yeah.
Thank you so much, Dr. Sharma, for adding more to it and also sharing that concern is not yet over. We have to be alert. I can see that Dr. Pingle has would like to share his thoughts. Please, Dr. Pingle, over to you.
Thank you, Dr. Pawan, and thank you, Dr. Jain, for an illuminating talk. As always, a very steady talk. I have a simple and small question for Dr. Jain. He has very rightly said that in this global world, if you immunize only your country, then you are not safe. Unless the whole world is immunized, no country is safe. So should India, in the current stage, share some of the vaccines, some of its vaccines with the neighboring countries, especially Nepal and Bangladesh, with which we have a lot of interaction and people movement? Because that is also a threat to our country, people who are coming from there, and we cannot stop that because that is not through flights. So should we share it, some part of it, at this point of time? Dr. Jain, please.
Dr. Jain, you have to unmute, please.
Yes, very relevant and very important issue Dr. Pingle has raised. Thank you, Dr. Pingle. Because of the epidemiological fact, because I did not present the South Asia, Eastern Asia micro data, while we are reporting less number of cases every day and less number of deaths every day, the same is not happening in Bangladesh or Nepal or even in Sri Lanka or even in Pakistan. The last week's data, 7-day average, if you look at the data and compare, they are reporting more cases than the previous week. So we are on the decrease. These three countries which India is surrounded by, that is Bangladesh, Nepal, and Sri Lanka and Pakistan, are all reporting higher number of cases. So we really need to work together if we really have to contain. Because of simple reason, this virus is not recognizing country boundaries at all. If you look at even India, if one understands that the northeastern part of the country is showing a huge test positivity rate as well as huge infection and transmission. Same thing is happening in Nepal. Same thing is happening in Bangladesh. So it's important to collaborate, work together, not only in terms of vaccination, but also in terms of strategic implementation on the ground. Because of simple reason that the borders are very porous. People keep on moving from India to Nepal or India to Bangladesh. There's no bar on people's movement. So it is important. I feel as the production of vaccine improves, one should consider helping these countries in not only not only having the vaccine, but also having technology for production of vaccine, because that may also help India in times to come. And that is why India together is fighting the WTO for transfer of technology. And that is why India have to have its act together. All countries have to move together to ensure that maximum vaccination is done on the ground, as well as maximum variety of vaccine platforms are available to people from in India, Nepal, Sri Lanka, Bangladesh, and including Pakistan, I would say. And now a new danger of Afghanistan is coming. Afghanistan is showing very high transmission in the last week. So one needs to work upon this very important issue.
Thank you so much, Dr. Jain.
Yeah.
Because this was one issue, this was one thing which our government tried to do in the beginning, but then the politics came in and they said, where are you sending my children's vaccine? Now they will say, where are you sending my grandchild's vaccine?
That's politics will go on, but science will remain science. And pandemic, as I showed you, the figures are very evident. Pandemic is very much there for long period. It's not going away.
So for this purpose, we have to consider Bangladesh and Nepal as part of India.
Very true.
Yeah.
Very true.
Okay. Thank you so much, Dr. Pingle sir, and thank you so much, Dr. Jan, for elaborating on this. Before I move to Dr. Lele's question, I would request Dr. Hitesh Shingla to please share his thoughts. If Dr. Shingla is able to hear us. Else, I quickly request Dr. Lele to please ask his question. I think, but the question probably has been answered in half. Dr. Lele, please, over to you.
I have come across a couple of people who had COVID after second dose and few people after first dose. What it means is that vaccine is not really helping. And if there is no help from vaccine, there are no medicines except supported isolation and quarantine, there is nothing. And maybe appropriate behavior. Is that the only solution we have got right now?
Well, Dr. Singhala, we need to understand one epidemiological fact of vaccine efficacy. What is the efficacy? And if you have seen the chart I have shown for the 4 variants, the infection prevention is not the goal or the aim or the certified quality of any vaccine which is available in India or most of the places in the world. The only efficacy is in terms of preventing death, number 1, preventing hospitalization, and preventing moderate or severe infection. The infection cannot be prevented by any vaccine available today. So people should not understand at all that they will not get infected. But definitely the data is available in Indian situation, especially healthcare workers across India, that it has been successful in preventing deaths, number 1, and in preventing severe deaths, especially hospitalization in the ICU.
Okay.
So we must understand this fact. And precisely for this reason, people who are vaccinated must continue COVID appropriate behavior 100% always. There should be no letter.
Thank you. Thank you so much, Dr. Jan, for taking up that question. I have a question from Dr. Prakash. How sure are we? And I think Dr. Prakash can unmute and ask the question. Please, Dr. Prakash, if you are hearing us. Okay. No problem. Can I then move to Dr. Tachycardia for his comments and suggestions and also his views. Dr. Tachycardia, please.
Well, good evening, sir. I think Dr. Rajiv Jain presentation of COVID SARS-2 is a superb, more enthusiastic, passionate, is very much concerned and dedicated on the subject of COVID SARS-2. Very nice presentation, sir. You have explained everything very beautifully and answered some of our learned speaker like Shyam Pingle's question. Very nicely you have answered. Thank you very much, sir. I just wanted some of the things is that we had a very bad experience in COVID SARS-2 because I'm also a practitioner in Bangalore and I also see a lot of cases and I also refer to a lot of cases. We have lost so many good people in Bangalore because some of them really got into mucormycosis and died in very big institutions. And these are the, if you analyze very carefully, I think in certain small hospitals, industrial oxygen has also been given, and maybe that is also one of the cause. And second thing is, until unless we give lot of vaccination, I think we cannot expect more recovery from the patient. Because today, most of the people, it is inevitable, they have to go for work, they have to do some work for earning. And first vaccination, I think statistically, if you take those who have been vaccinated, they are nearly survived. Those who are second vaccination, at least they can get into some sort of an help. That is a medically, they can overcome between 90 to 95 SpO2 or up to 90 they can come. Those who have not taken vaccination at all, they are miserable. Some of them have expired, or some of them are really facing a lot of this one. And I have seen 2 cases in Aster CME hospital. Their ECMO has been done and they have been asked to go for a lung transplantation. One is our anesthetist who was in Prakriya hospital. Another is a man who has returned from US after to see his mother because his father was expired. And both are in a lung transplantation, and the estimation is around 70 lakhs. So what I request Rajiv Jain ji is, sir, will you say that this vaccination will really help our people to overcome this kind of a Delta or Theta, whatever the variant? Will you please throw some light on this COVID SARS-2, sir, this way, especially the variant of concerns?
Thank you, Dr. Dagaraj, for your kind words. Your very relevant question you've asked. As I showed you the vaccine efficacy data for the 4 variants of concern in one slide, you would have noticed the studies have been done for mostly 2 vaccines, and third is, of course, Bharat Covaxin. Covishield and Bharat Covaxin, the available data has been published and recognized by World Health Organization. The slide I showed you was from World Health Organization, which has been released with the last week's epidemiological update. And it clearly shows that it has definite effect for the Delta variant for hospitalization and moderate to severe disease. But for mild, yeah, of course, the infection, it is not protecting at the moment. So let us wait for further research, but only we must understand that only vaccine will not do. Vaccine combined with COVID appropriate behavior and especially protection in indoor areas where ventilation is of paramount importance. Open air, COVID appropriate behavior, distance, mask and sanitization. But more important is 100% coverage of ventilation and mask and distance in indoor spaces. So only this way one can prevent. There is no other way we can prevent. We see the virus will not say I am Delta and I'll attack you. So start your protection now. Virus will always be there and it's waiting. It is waiting always for the susceptible people. So it is going to infect. So one should understand it is not vaccine which will save you. It is combination of the 2 and 3 now. 3 is ventilation. Second is your COVID appropriate behavior. And first is vaccination. All 3 combined will save you. 1 alone or 2 alone will not save.
Well, I think that was.
Thank you.
Yes, sir. Yeah, that does elaborate after that. Only we are the last question of the day, and with after this, we would definitely proceed towards the conclusion of the webinar. And over to Dr. Prakash. Please, Dr. Prakash.
Hello. Good evening, sir.
Yeah, good evening.
Good evening. I'm Dr. Prakash. Yes. I work in an industrial hospital in Vizag, the Vizag Steel Plant Hospital. This time we have experienced a huge number of patients, like 800 plus patients in 1.5 months. But what we see in this second is, we have very little time to attend to the patients. They come with a 2 days, 3 days history of the symptoms, and suddenly the oxygen drops down to 90, below 90, 85. And before we could even initiate the treatment, people expired. And many people were brought there from the house, expired, maybe up to 15 to 20 patients. So compared to the wave 1 to wave 2, we see that this duration of period of treatment was very less in the wave 2 compared to wave 1. So this I suspect whether this delta was there in the second wave itself and we missed for this acute shortage of time for treatment of these patients and a lot of mortality.
Well, Dr. Prakash, you very rightly said, and this we now almost officially said that second wave was predominantly the Delta variant in India. And also that is why Delta Plus is being declared as the variant of concern for India without bothering for WHO or any other country declaring it as variant of concern. India has officially declared Delta Plus as the variant of concern, and it has officially told the chief secretaries of states like Maharashtra, Madhya Pradesh, Punjab, and Kerala, and Haryana that they need to understand that this variant of concern, Delta Plus, is there in their states already. And they have to now improve their genomic analysis of more samples and also understand, as if you would notice in my presentation, I showed you what are the clinical symptoms of Delta Plus. Delta Plus clinically is a distinct entity now. And ICMR and INSACOP are working very hard to nip it in the bud. Unless we understand that this is the only way, because of simple reason that vaccination is still on. There is a large population which is not vaccinated. Yeah. And there are a number of spaces in India which are closed spaces and have poor ventilation. And now opening up has happened to transmissibility, mobility of individuals has increased. So likelihood of spread of Delta Plus is very high. And that is why the foundation for third wave is being laid. Foundation for third wave may have been laid already. We need to keep a watch. That is what the core message of my presentation today has been.
Yes, sir, I agree. In the second wave, we found that vaccination has really helped our healthcare workers. We could vaccinate all our 400 plus healthcare workers in the hospital. And out of that, we had about 20 doctors and 30 nurses got infected, but none of them got admitted. They recovered back and they came and joined back to duty again. So that was the advantage of the vaccines.
Yeah. Thank you so much, Dr. Prakash, for the question. And we are really glad and thankful to Dr. Jan for taking up all those queries elegantly and providing us the answers to the most concerning questions and important topics for the for current situation. We are definitely in constrained times. Looking forward for a better future and good time with a hope. And with that, I once again thank Dr. Rajiv Jain sir for his presentation and also for all the information that he has shared. Thankful to all the panelists and attendees for making these continuous efforts of AOHD Delhi a success, because without you joining in, without you interacting and reciprocating, this will never be possible. So with those words, I go back to Dr. Rajiv Jain sir for final comments and then we conclude. Please, sir.
Well, I must say we must continue our guard and prepare for third wave because of Delta Plus variant being widespread in India by now, and also increasing number of new states are showing Delta Plus variant in their population. And this is going to affect all of us. We must understand a different lifestyle has to be lived, and different lifestyle has to be lived for a very long period.
Yeah.
We must prepare and have patience to understand that we have to save lives and livelihood. There is no other way except to continue to have COVID appropriate behavior, prefer outdoors than indoors, and especially not go in indoor spaces with poor ventilation, and complete your vaccination as per schedule at the earliest opportunity. So these are the key messages for today's COVID-19 epidemiological updates. Thank you so much for giving me an opportunity to discuss the epidemiological aspects of COVID-19. Thank you, Dr. Pavan. for very efficiently conducting today's webinar.
Thank you so much, sir, for your kind words. And we always are really thankful to you for all the support that you extend. With those words, I wish you all a wonderful Saturday evening and definitely a great Sunday. Look forward to connect with you once again on next Saturday at 6:30 p.m. Thank you very much. A very good night to all of you.
Thank you.